Hello, everyone. Welcome back to my YouTube channel again. You will understand I'm doing few more videos immediately after I started my channel. There's a reason for this. It's actually a lot of people who are planning to come to Australia or are in the process of applying for medical jobs in Australia, actually requested some sort of touch base of different topics. So that's the reason for today's talk, actually. What I'm going to discuss today is like how to navigate the Australian healthcare system or how to navigate first few weeks of your job in Australian hospitals. So, or in other words, this is how to survive your first few weeks in Australia. This is targeting not only Sri Lankan guys, this is also important for other international medical graduates coming from India, Pakistan, any other country, Europe, anywhere else. But this is mainly, I think, some of the things I would be discussing would be mainly applicable for our colleagues who are coming from Asian countries, so Asian background. Like culture like Sri Lanka, India, Bangladesh, Pakistan, that sort of a culture. So I'm going to address this like topic in few different areas. First thing is when I say how to navigate the Australian healthcare system in the first few weeks of your life here. First is how to sort of manage people, which is like how you manage your colleagues or how you interact with your colleagues in the same team, same medical team, your supervisors, your like registrar and other HMOs, medical students, interns, likewise. So how to navigate your team, medical team, with medical team, plus how to deal with like nursing um, staff and other, like, here you get ambulance officers, radiographers, psychologists, physiotherapists, ward clerks, and there are so many other people you have to interact with in your first few weeks of work here. You will continue to interact with them, but you will find some challenges when you first coming in here. So I'm going to discuss those things, how to sort of navigate with these areas. And then the second area I would be touching upon is like how to deal with patients and families. Okay, patients and families, which is like your clients. Okay, and then the third is, of course, which is very important because you come to a new healthcare system and a new, very like a structured health system. So how to navigate the Australian healthcare system in that way, like different organizations like Medicare, and there's other organizations like PBS or Pharmaceutical Benefit Scheme, which is again Medicare, and uh, and then how to sort of deal with work cover issues. You will understand these things when I talk about, and then how to deal with accidents, and it's called TCA, Transport Accident Commission, TCA. So those things, because your patients who are coming in have different problems. And then when you're addressing those problems, if someone comes after, for instance, work injury, you'll have to deal with Work Cover Australia. So you should know what to do. And then if you want to prescribe some medication, you will have to deal with PBS sometimes, like get the authority from the PBS and things like that. So you need to know PBS for Pharmaceutical Benefit Scheme. And then there's Medicare. Some people have Medicare, some people don't. And then you have to talk about how to deal with those things. So I will, my third part of my sort of talk in this talk itself, I'll try to touch upon those ones. So the third part, I will cover how you deal with these different systems and organization. Finally, but most importantly, is like your IT, or how to deal with computers and Australian sort of healthcare system. We don't write hand notes, but we don't write notes, but it's more like typing your history and typing your discharge summary and faxing things and emailing things and things like that. So I will touch upon those areas. Okay, let's start with the first thing, which is how to deal with your team. Okay, supervisor. Start with the supervisor. Most of us coming from Asian countries, like I know Sri Lanka, but all of you guys know how you deal with Indian supervisors. How did you, what sort of experience you have as medical students of your, say, consultants or supervisors. Uh, this is a bit different, okay? First of all, when you come to Australia, there's no sirs or ma'ams here or madams here. Like ma'am is, I think people use it in India. And Sri Lanka, we call it madam. So, but we don't have madams or sirs here. We just say whatever the first name. If you want to talk to me, you would say Kirti, right? There's no Kirti sir or uh, like another, I don't know, Melanie madam or something like that. But there's no such thing. You just talk to them by first name, or if you want to use the prefix doctor, then you use the, like, Dr. Kulasekara or something like that. Use the surname. Okay, so that's how you talk to your supervisors, generally with first name. Okay, you say Ed, Ben, Robert, Bill, anything. Okay, so you, or Kirti, myself, or any other name, but you call them by first name. Okay, and then there's no saying namaste or worshipping or anything like that when you want to thank. You just say thank you with shaking their hands. Okay. Uh, and when you're dealing with the supervisors, because of our sort of upbringing or background, and like in our medical schools and in our training, most of the time, I know this is happening in most of Asia. So you get laughed at or ridiculed or sort of looked down upon or something like that when you do a mistake when you're presenting. Okay, you present the case and then you become a laughing matter, or you tell something out of the ordinary in a case presentation, and then they would say they will put you down. So it's a bit different here. Therefore, what people coming from our part of the world tend to do is like they talk very soft, including myself. Okay, when I first started, it was the same, and you very scared of talking loud, and not because you don't know the subjects. Okay, you know your medicine well, but the problem is you got this what we call a respect, right? Respect. You try to respect your supervisor by not talking aloud or talking soft, and expecting some bad reaction. Okay, unfortunate situation in our part of the world, but so you expect some bad reaction from your supervisor if you say, okay, this patient presented with central chest pain which is radiating to his left arm, and then it's also radiating to the back, and then he sometimes has some sort of discomfort in the jaw as well. I realized that he got some diaphoresis, and he also says that he get a bit nauseous. Given his strong family history of cardiac illness, like ischemic heart disease, and he's also a past smoker, I'm suspecting something cardiac. Therefore, I'm going to order troponin, ECG, and I'm going to do, before you order the investigations, you will be say, I'm doing chest x-ray and chest x-ray, ECG, and troponin and other bloods, UEC and full blood. And at the same time, in my examination, I found these things. And then you might have sort of examined something irrelevant for the presentation sometimes, okay? But you would be sort of, even if you present that one, they say, if you got the required information and you are in the right path and you managing it well, they don't laugh at you doing something odd, like a little thing. I would say something like, for instance, requesting CRP or ESR or something like that. They would say, oh, yeah, why you order, but what was the rationale behind it? But other than that, they won't say like you threw in everything and why you did that and this is wasting and all this and that sort of thing won't happen. But in your training, you will get the training that you don't need to order that sort of unnecessary investigations. Anyway, if you present the case that way, that's what you have to do, but you have to raise your voice a bit and assertive, and then you talk like, okay, this is what I'm looking at, and then my most likely diagnosis is this, therefore I'm working towards that, but in the meantime, I want to exclude the other conditions. So that's why chest x-ray, okay? That was like in, like chest pain, if you go for a chest pain case, for instance, you will have to rule out any lung pathology or like, aortic dissection, for instance, if the pain is sudden onset. That's why you're ordering a chest x-ray, so you can justify. Anyway, if you kind of presenting that sort of a case to your supervisor here, and then if you give the, okay, this is the history, this is the examination, and because of this background history, I'm going to do these investigations and manage as this, he would be happy, and that's what you're supposed to do. But if you got those inside your mind, but you not express them and sort of waiting to see like, okay, you give a little bit and then you don't tell the other bits because of worry that he might laugh at you and he might shout at you or something like that, that's not going to go well, okay? That would be looked as if you are not confident enough or you don't know the case or you don't know the subjects or something like that. That's the difference here. If you suspecting something and if you are on a path of sort of getting the case this way and you handling it that way, you just express that and then you tell everything. And then if you are not sure or if you're uncertain, still expressing uncertainty is also important here. Not like back home. If you're uncertain, they would say, oh, this guy doesn't know anything or something like that, okay? So therefore, talking and expressing yourself and raising your voice and talking about your differential diagnosis and then talking about your management plan and why you sort of taking the case this way and things like that would be very well accepted, okay? So talking to the supervisor, no, sir, madam, but you talk about your history, examination, investigation, and management plan. That's the way we talk. And then because you are HMO or registrar, if you are HMO, your registrar and your consultant will give you a plan. Otherwise, if you are a HMO, your registrar or consultant will give you a plan. If you are a registrar, your consultant will give you a management plan, or he would say, oh, yeah, you are on the right track, mate, or you have to change this because of this. He will give you his expert opinion, but he won't laugh at you. Okay, so message here is not to become shy or not to show the respect by sort of lowering your voice and not presenting it, showing any, like, eye contact is very important here. You talk to someone, you look at them, okay? And then, like when back home or when we are medical students, for instance, we would be looking down and then talking. It's not the way to sort of present cases. With the colleagues, dealing with other colleagues, like medical students, registrars, other doctors from other teams like medical ward, surgical ward, psychiatry ward, and dealing with ambulance officers, nurses, nurse unit manager, ward clerks, everything. You should be sort of very open-minded and talking freely. And then there's nothing to worry on. the other way, like there's no hierarchy here. So we won't sort of expect them for us to say doctor or sir or madam or anything. They would also call us in our first name, okay? And then here, I will touch upon a few things, right? There's Australian slang or different words people use. You will come across these things, or you can Google search those terms. For instance, how are you going? They would ask, Kirti, how are you going, mate? And then that's not like I'm going by bus or I'm going by bicycle. It's like, I'm doing well. I'm fine, thank you. How are you doing? So that's the way you would be sort of expressing. That's like different ways of using the language. And more than that, other than that, there are other words coming, but I'll discuss that when you're dealing with your patients. So dealing with your supervisors and the team, mutual respect, but there's no extraordinary respect. Okay, you're not worship them or say namaste or anything, or say Aibon, bend your head or anything like that, kneeling down or nothing. And you talk to them with the first name. And if you want to be a bit more respectful, you feel like, oh, I can't use the first name, then you say Dr. So-and-so, Dr. Mackenzie, Dr. Blessing, or something like that. So their surname. Otherwise, first name. And it's the similar way you talk to nurses, A&Ms, clerks, and everything. You don't look down upon them. They are equal like us in the team. We have to be careful with some of our body language, which is coming with the language we spoken or way we express in ward rounds and things in our part of the world, say India, Sri Lanka. I have seen this with not from a Sri Lankan doctor, but another country. Like they use those like facial expressions just when they talk, but it sounds like to the receiver, it sounds like they're not happy. Okay, but it is not the case. That's how she talks. That's all. But this is challenging scenario, not only for you who coming new here, for the people, the teams here also, they have a bit of a challenge of understanding these different sort of behaviors, like slight cultural or practical practice differences. Okay. Anyway, I think I have covered enough for the how to deal with your medical team. Then go to the nursing and other teams. As I said, you show mutual respect, and then you listen to them, and you actually listen to them, and they can question you. This is the part I have to talk about here, because we are like guys from Sri Lanka, for instance. They might not that used to like nurses telling them things. Okay, why are you giving salbutamol here? Have you got a diagnosis of asthma? Or pharmacists would ask you, have you done the creatinine clearance? What's the creatinine clearance? Why are you giving gentamicin? Is this gentamicin dose is right? Or have you done the, say, epilin level or lithium levels? Have you done digoxin levels, gentamicin levels? Okay, the pharmacist will ask those questions, or they will ask you to order. So therefore, the members from other teams actually interact with you to make sure that patients get good care and accepted care. Okay. When I give those examples, for instance, I don't know, is it a common practice or not? But this has happened in one of the meetings we have with, we always have Zoom meetings with other GPs in, I think, RSCGP meeting. In one of those meetings, they were talking about someone ordering oral salbutamol, for instance, because in Australia, we don't use oral salbutamol, syrup or tablets, nothing, because we mainly use puffers Ventolin puffers or salbutamol puffers, or if they can't tolerate the puffer, you use the nebulizer. I will talk about asthma management and everything later, then you will understand. But it's a good practice before you come in here. Probably read about some guidelines, asthma management guidelines, Asthma Australia or RCH website to find out how you manage asthma. RCH got good information about how to manage asthma, acute asthma, because as a ED-HMO, you will be dealing with acute asthma, not like prevention, asthma prevention. It is GP's arena, right? So acute asthma management, in a nutshell, if I mention, like people try what we call a burst therapy, like, if they're less than 6 years old, you give 6 puffs of Ventolin, and then you repeat it every 20 minutes. You try it 3 times, give a high dose of oral steroid if it's not settling, and otherwise you escalate with the seniors and with PED team and ICU and things like that. Okay, so I'm not going to talk about the asthma management here, but what I'm trying to say is like it's a different ways of managing asthma here. So oral salbutamol is not used, not mentioned. Okay, so likewise, the teams from the like a pharmacist side and the nurses side, they will sort of question some of your practices, because sometimes, because if you are not used to, or if you don't know the guidelines here. If you know the asthma guidelines, you know what to do. And then if you know, for instance, like guidelines in managing other conditions, even MI, and then even when you're ordering investigations, or I will give you an example here. If you do a CTPA, if you requested a CTPA, then the radiologist would expect you to give the EGFR of the patient. So this you will learn while you're working here. But if you know that you have to do EUC, or LFT and EUC, you will find out the EGFR. So then you give that EGFR to the radiologist when you order the CTPA, right? Or anything using a contrast, any imaging using a contrast, you will give the EGFR, renal function of the patient, right? So therefore, the other teams can ask questions or send you emails or send you messages. You don't have to get sort of worried or deterred or anything like that, but you say, sorry, I missed it, but this is it, yeah? Or you talk to them and then give it. It's not a usual practice in our countries. That's the reason, like our part of the world, like because of the hierarchy, the nurses or pharmacists or other people from the health team won't question doctors that much, especially the consultants, right? Like the specialist. But specialists back home come here as registrars, right? For their overseas training. That is when they find this some challenging situation. Some of the colleagues come from Sri Lanka, for instance, asked or told me these scenarios. So that's why I was talking about this, especially about pharmacists questioning their management or pharmacists asking for further information. Mm-hmm. So therefore, when you deal with these teams, they are equal like us. There's no hierarchy, and they know their subject very well. They are actually trying to help the patient and yourself and the healthcare system by raising these issues, okay? It's nothing personal against you, but it's more like to help you yourself and the patient, yeah? Everyone involved, pharmacists, nurses, specialist, team, and yourself, and the most importantly, the famous. They wanted to avoid any harm happening to the patient, right? So when I say these things, you don't comment down here saying, you have faced all these scenarios. No, not myself. I might have one or two, but not all of these happen to me. But I'm talking to so many international doctors for years now because I was preparing exams with them, and then we were discussing cases with them. And then lately I was guiding them to do their exams and things. So, or how to navigate with the Australian health system. I have guided many people when they say, there's a problem in my unit, I have this problem. And then I would say, okay, this is how you manage this. So I got some experience of those arena. That's why I'm talking about this, right? Okay, this is the second part, how to deal with others in the team. And then the third and most important part is how you deal with the patient and their family, okay? Here in Australia, or for that matter, developed part of the world, not the third world or not the subcontinent like you and me. So the patient is considered most important person when you're dealing with a clinical presentation, right? So we should uphold their rights, and then their rights for privacy, confidentiality, and then you actually manage patients by talking to them. It's not like you have your management in your mind and then you put that onto the patient, but it's rather what you do is like you have a sort of mutual like understanding and talk back and forth with the patient and tell them, okay, this is what I'm going to do. I'm going to request this investigation. I'm going to examine you for the consent, like I want to examine you these parts of the body. Is that okay? So it's a bit different to back home again. So you respect your patient and you respect their wishes, and you respect their rights. So patient got all rights in the world to question you. Like they could question anything, right? Why you booking me again? They can question you if you ask them to come back again. Or why you asking these questions? Then you have to explain, okay, this is the reason. So they could question anything. Your management, they could question why you giving this antibiotic, what's the action, and what are the side effects. A lot of Australian patients are well educated, right? They may be doing Dr. Google or otherwise. They will aware about conditions and management and things. So it's very easy for us to deal with them, such people, but you have to know your stuff too. So they could question you, but you should be ready to answer. Okay. And then, as I said before, you respect their wishes, and then it's like it's a mutual understanding, and then it's like a team affair between the patient and the doctor. And then you always do things after discussing it with your patient with their consent. This is in a nutshell, but there's more things into it, but this I will discuss in a different video. But when the patient's family dealing with you, again, especially aged patients or young patients, the family got a lot of rights to discuss their mother or father or the child with you. In between, confidentiality coming into play. Without patient's consent, you won't be talking to the family even. Okay, but if the patient is incompetent, then you will have to sometimes compassionate ground you have to think about. This is again, I am going to cover in a different topic, but what I'm saying here is like you should be ready to talk to your patients and their families and deal with them over the phone, or if they send you an email through the reception, you reply to them again or make a call or get them in or things like that. As a GP, I'm talking about. But in the emergency, again, you explain everything you do to the patient. Especially in a real emergency scenario, there's a person who's specially allocated to talk to the patient's family on the by the bedside. This is a usual practice in very busy emergency departments. Okay, so what I'm going to tell you is like, it's not like, okay, this is your tablet, go home, but you will be talking to the patient most of the time and to the family and explaining things and tell them side effects, and if they're worried about side effects, give them another option. Okay, so this is a bit about how to deal with the patients. But here I'm going to bring in some other information. This is again like Australian slang, for instance. Okay, so they say, doctor, I got a problem in my ticker. Ticker. Okay, ticker here is heart. Okay, so they're talking about heart when they say, oh, there's a problem in my ticker. And tummy, and then they can say, I was sick yesterday. When they say sick, it's like they had vomiting. Okay, or I was spewing yesterday. Spew is like vomiting again. And then they use number 1 and number 2. Okay, number 1 and number 2. Or they would be talking about pooping, or like pooping they use for defecation. Likewise, they can use different terms. So you should be familiar with some of those terms. If you don't know, you say, okay, sorry, can you explain it to me? Then they will tell you. Okay, so you can always ask them. But beware of those terms, right? And they want, again, the patients either use to talk to you in first name, or when you say, hi, I'm Kirti, your doctor today, and then they say, hi, Kirti, nice to meet you. So they will talk to you in first name, or they would say doctor, they might, and then sometimes they may use doc, DOC, anything. So it's like simple dealing here. Again, the eye contact is important when you're dealing with patients. This is important when you do an interview even, or when you're doing a scenario. Okay, you look at the patient. And this is that's covering the part of how to deal with patients and families. There are a few other important things I want to cover today. The other one is like how to deal with the systems or different organizations. Mainly, if you're working as a doctor in an emergency department, you may be dealing with the computer system, and then referral systems, and then dealing with other teams to refer, and then things like, as I said, PBS, pharmaceutical benefit scheme, and then things like Medicare, and then things like work cover, and then the last one I wanted to touch upon is like the TCA, Transport Accident Commission, TAC, sorry, Transport Accident Commission. I'll try to sort of explain those things. First, when you refer to a ultrasound scan, chest X-ray, CT, anything, you will have to put your name, signature, your provider number, and if you got a rubber stamp, you put the rubber stamp there, and then sign and date it. Okay, and then you either fax it, or if the radiology department in the same area, so you just hand deliver, or you put it in a socket or a box or something, and then they will take it and call the patient in. Likewise, the pathology slips goes to the, the laboratory. So you collect your blood samples. You do it yourself in emergencies here most of the time. Not the nurses or anyone, but you do yourself. Nurses can do, but generally the doctor himself collect the blood. And when they put the cannula, and then you write your investigations, put your prescriber provider number, or your rubber stamp, sign, dated, and send it to the pathology with the in a plastic bag. Most of the emergency department have a sort of a quick delivery system. If I'm just trying to recall what I used to do in Bendigo Base Hospital, old hospital we were training. Now we got a new hospital. And in that one, the pathology was in upstairs, level 3 or 4 somewhere, but level 3, I think 2 or 3. And then what we used to do is like there was a chute, like a plastic tube with vacuum or pressure, dragging that bottle right up to the lab. Okay, so what we were doing is like you put your request and like your tubes with your blood or urine or anything, and then put it in that chute and press the button. Then it will go to the lab. Okay, so I remember doing all this myself. And then I remember even doing a urine ward test myself, collect a urine sample from your patient and do a dipstick. If you, for instance, if you suspect ureteric or urinary calculi, one thing you would be doing is a dipstick to find blood in your dipstick. So, or if you suspect a UTI, you will be doing a urine dipstick. And then if you wanted to sort of rule out pregnancy, for instance, you will be doing a pregnancy test. Those things, you collect a sample from your patient, you do it yourself. You don't wait until the nurses, but I'm not sure. I haven't asked nurses to do this any time at all. All the time I have done it myself as HMO. But if you're busy, you could, or the nurse is free, you could ask. There's no harm, but generally they're busier than you. Okay, because they got 7, 8 patients allocated, you got only whatever patients you got at that time. Anyway, what I'm trying to tell you is like if you refer patients, if you send things to the labs or if you send things to the radiology, that's how you do. I may miss few areas here because I'm trying to tell you some of the things I could remember from my emergency dates, which is like 10 years ago now. Okay. The other thing about this dealing with other people or other institutes is like dealing with I told about dealing with labs and radiology, but they are very close to the emergency department generally. But this, if you are a medical person or if you're working as a GP, this is a bit different, but still you have to put your provider number, signature, date, and request what you want and give a bit of a history. So this is usual practice, okay? So you just do it that way. And then why you ordering that one, query that, exclude this, something like that. Or you order thyroid function test because he's on thyroxine, this dose, and we currently titrating the dose, something like that. When dealing with other organization, very important, I think time would be okay for us. I wanted to restrict this to less than 1 hour. Anyway, when you're dealing with PBS, pharmaceutical benefit scheme, you better know about PBS before you come in here or immediately after you come here, or you quickly recognize what are the things in PBS and what I have to do when I order this sort of medication, when I prescribe this sort of medication. And so get used, right, about PBS. What is it important about PBS? Like some of the medications are PBS subsidized, most of the medications for the Australian permanent residents and or the citizens. But some of the other people who Australia have connections with, like Swedish, Danish, and things like that, they got Medicare cover. They get PBS subsidized medications. But most of the other people, like, if they come for a student visa or work visa, they don't have the Medicare. Then they have to pay everything out of pocket. But the Australian people, or Australian resident and permanent residents and citizens, they get like a substitute, like a subscription coming from the government. Therefore, you get only medication to a lower price. Okay, so if you know that this is PBS subsidized, and then those medications you can order freely. Like for instance, metformin for diabetes, you don't have to get any permission or you don't have to talk to anyone. You prescribe metformin, say 500 milligram twice a day, and then you sign and you put your provider number as well as prescriber number here. Prescriptions, you have to put your prescriber number. I'll talk about provider prescriber numbers in a different video, but these are the things when you first come into Australia, you will get those two numbers first before you work here. So you have to put those two numbers in your prescriptions. And then when you're writing prescriptions, if you write like a PBS subsidized medication without any restrictions, like metformin for diabetes, that's one example, or amoxicillin for a chest infection, you don't have to get any other authority, but you prescribe, put the dose, frequency, for how many days, before food, after food, and then you sign, date, prescriber number, provider number, send it. Okay, so then the pharmacy will issue the medication. The problem or the restrictions comes with some other things. There are other medications. You have to get the authority. Sometimes it's called a streamline code, which is like if you go to just go to the PBS website, Pharmaceutical Benefit Scheme website, www.pbs.org.au, I think, but I will put a link here. And then you will find, if you type search, in the search item, you put your medication, then you will find out from the PBS itself whether it's a restricted medication or whether it's a streamlined code medication with a streamlined code, or is it like no restrictions. So medications like metformin, short course of amoxicillin, no restriction, 6 days course of amoxicillin. But medications like olanzapine and quetiapine, for instance, got a streamlined code for schizophrenia and bipolar disorder. So you can't prescribe for other things without the authority from PBS. But these two streamlined codes you can use. Likewise, medication for diabetes, for instance, got some conditions like other medications, other than metformin and biguanides and sulfonylureas, like other medications, oral medications you can prescribe without restriction, but the other newer medications, I'm not going to go into details of all those medications. This will drag on for hours if I am to, but we will touch upon these ones in a different video. Anyway, what I'm going to tell you is like, if you got a streamlined code, you will find it from your PBS website, and then when you write the prescription, you put that streamlined code. Okay, authority. There's an authority column. There you write the streamlined code. For the GPs here, actually, we got a system-generated prescription form. In that one, it comes the streamlined code into the printout. Okay. Then verbal, like a PBS authority, you have to ring PBS. I think 1800 something, I can't remember, but that number people will remember, 555 or something. And then you ring the PBS and get the verbal authority from an officer in PBS. We usually tell our patients, okay, I'm going to talk to Canberra, that's the PBS. And then you get their code, authority number, then you put that number on the prescription and issue the prescription. This would be done if you give extra doses, for instance. Usual doses, like say, if you give sertraline 100 milligram once a day, and then you wanted to up the dose to 200, then you'll have to probably get the authority to get extra amount of tablets. So if you need that authority, you ring the PBS. I give you one more example. If you want to give, most of the antibiotics here are streamlined, or they're needing PBS authority. When I say most of the antibiotic, not the common ones, but the ones freely used in our part of the world. Okay, for instance, ciprofloxacin here, you have to get an authority from PBS. Cipro, from my memory, is restricted to use in Pseudomonas and resistant organisms. So you have to have a urine or blood or whatever culture with positive results to get the authority, right? Otherwise, you could say, okay, I'm suspecting this and give me the authority. Probably they will give you, but usually, based on your previous experience with the similar infection, but usually you should have the culture positivity to get the authority. I can give you one more example. If you want to give ceftriaxone, ceftazidime, or tazocine and things like that, you again have to get the authority either from the PBS or from the ID physician, infectious disease physician in the hospital. Usually in hospital ID cards, I will show you that. This was one of my ID cards when I was in hospital. This is many years ago, but still I have some of it. You see here, I'm just trying to get this one. Antibiotics that require approval. I don't know whether you could see because of the light. So they got a laminated form with antibiotic that require previous approval. Here they say, I can see here, cefotaxime, ceftazidime, ceftriaxone, ciprofloxacin, clindamycin, doxycycline IV. So some of the examples. Yeah, I'm looking at my hospital ID many years ago. Anyway, usually the hospitals will tell you these antibiotics would require authority, but otherwise you can learn them from PBS. Yeah, but remember, antibiotics in Australia, or for that matter, other developed world, they don't use it haphazardly. They get really restricted indications, and like especially just to avoid this antibiotic resistance in the community, they use antibiotics sparingly. And then, as I said, for antibiotics like Cipro, ceftazidime, ceftriaxone and things, you have to get the prior approval. Okay. Before I finish the video, I think the last bit I have to talk about is how to deal with TAC and work cover. This is here, you will learn it later when you come to the hospital and come to work. But what you have to remember is, like, if a patient comes after a road traffic accident, that would be a TCA case, or the TCA certificate has to be offered or given to the patient. And then if the patient comes after an injury from the workplace injury, you have to give a work cover certificate instead of just a normal medical certificate. Patient has got all the right to request for a medical certificate. Then you have to give a medical certificate for how many days you think the patient should be out of work. But remember, we generally don't backdate the medical certificate. If the patient asks you to backdate the medical certificate because they were ill for however many days, what you do is you do a statutory declaration, stat declaration, okay? And then ask the patient to do it, and then you sign it. I think I covered what you would like to hear, like how to deal with the Australian healthcare system in your first few months being to Australia, okay? If you have any questions, please put them under the video and then I'll try to answer those questions. Thank you.